Are you feeling overwhelmed about sitting the MRCGP SCA? You might feel that this is a daunting exam due to the uncertainty, the wide curriculum that you need to cover, having to perform under exam conditions. In this video, I'm going to teach you three components that's very important. The first one is how to identify, assess, and manage risk. I understand that a lot of you are struggling to assess and manage risk. Management of risk is very important to understand what are the exact things that you're managing and how to go about it. The second thing that I'm going to share with you is how to think about the difference between risk and uncertainty and how you can assess and manage uncertainty in your practice. And the last part is how to approach ethical issues. So sometimes it's very difficult when you don't understand the ethical considerations, what to do in a case that's complex or tricky. Let me share with you a little bit about myself if you're new here. So my name is Dr. Erwin Kwun, and I'm a portfolio GP. I'm director of ACC Kwun. I'm on a mission to help doctors lead a fulfilling life. After I passed my RCA back in December 2020, I've been helping GP registrars to get through their training, especially their final MRCGP exam, and I'm helping them to get out of training. So I hold a PG cert in applied positive psychology and coaching psychology. I'm a big advocate of coaching because I've benefited from coaching myself, and I've helped a lot of GP trainees by coaching them, especially people who struggle after failing an exam or don't have a lot of confidence. So let's start with a quiz. You've got Dr. Smith, who is discussing the probability of developing a stroke and heart attack with a patient based on available data. He provides a patient with a likelihood of serious complication. What concept is a doctor addressing here? So we've got a lot of A's here, which is great. That's right. So A is a correct answer. This is about risk assessment. What is risk? Risk is possibility of harm or suffering. It is a potential outcome that is known. And risk is something that can be quantifiable, so you can measure risk. So normally we assess the risk and have a percentage that we attribute to the risk, whether it's a high risk or a low risk. So why do we need to manage risk? Management of risk is so important because it comes down to patient safety. By making sure that we identify and assess risk and managing it effectively, then we can provide quality care for our patients. It's also a responsibility that we've got, an ethical responsibility, to be able to assess risk of our patients, and then especially when it comes to discussion of management. So, for example, if we're considering a treatment, we need to consider what's the risk that the patient might have when they take it, and also the risk of not taking a medication as well. So this comes down to informed decision making. When you have this risk stratification, then you can inform the patient and support the patient to make an informed decision. Let's go over scenario one. So you've got Mr. Smith, who presents with a 2-day history of chest pain. He's known to have a family history of cardiovascular disease. Currently, he's pain-free. So can you tell me what is a risk in this scenario? What do you think is a risk that you're thinking when you're seeing a case like that? Yes, so risk of death here, heart attack here. Benedict says MI, Srujan says risk of MI. Completely agree with you. So there's different differentials when we're thinking of chest pain. MI, cardiac causes come first because this is a life-threatening. If we miss something like an MI, then the patient might die. So there's various causes. So there's also pulmonary causes such as PE, pneumothorax. There's also GI causes. For example, it could be a patient who's got pancreatitis. So risk factor here could be if the patient drinks a lot. There's other causes as well. For example, it could be anxiety attack or costochondritis. But the risk for these is quite lower. Is it cardiac? Because that's a major risk factor here. So is it a serious cardiovascular disease that the patient might have? And if you look at the scenario, one of the things that tells us thinking cardiac here is the family history of cardiovascular disease. So if a patient has got a family history, then the risk factor is higher. So when we're thinking about what's the risk here, we need to think about how do we assess the probability of a cardiac event. So various risk factors we need to consider. So age is something that we will consider. So if the patient is 75, then it's higher risk factor. if the patient is smoker, past medical history, and family history. So thinking about what's the likelihood and potential impact of each of the risk factor, then we can consider whether it's a low risk or high risk. So if patient is a smoker, if the patient has got a past medical history of hypertension, rheumatoid arthritis, or diabetes mellitus, and the family history is important to get more information. So asking about whether it's a first degree relative, and what was the age of that family member when they were diagnosed of a cardiovascular disease? If you've got a patient whose dad had a CVD at the age of 50, then that's a high risk factor. So when you're assessing this, you're thinking about what's the risk, and there's a Q risk-free system that's used commonly to assess what's the risk of a patient developing cardiovascular disease over the next 10 years. So let's say the risk comes down to 30%. When you're thinking about this 30%, it is something that is a bit abstract and it's difficult for a patient to understand what's the risk. So if you tell somebody you have 30% risk of developing a heart attack or stroke within the next 10 years, they might not understand what the risk lies, or they might be very anxious. So a helpful way to convey that and discuss the risk with your patient is to tell the patient, if we take a crowd of 100 people with the same risk factors as you, we would expect 30 to have a heart attack or stroke over the next 10 years, and 70 would not. By having these numbers instead of percentage, then it's more helpful for the patient to understand how this risk is on them. That risk of a patient of developing a cardiovascular disease over the next 10 years. Now, how are we going to manage this risk? There's various ways of reducing risk. So we can consider lifestyle changes, such as healthy diet, making sure that the patient is eating healthy. The second thing we could consider would be exercise. Is a patient having regular exercise? And the third thing is about medical management. So this is when we're considering statin to reduce the risk of developing a stroke or cardiovascular disease. So when you think about discussion of how to manage that risk, it's important that you consider the pros and cons of the medication. So what are the benefits of having statin, and then what are the disadvantages, inconveniences that the patient need to consider, because they are going to have to take this tablet every day, and it's important that we have this discussion with the patient. So when we look at the Q risk free of 30%, if we look at 100 people who've got this Q risk of 30%, if all of them take statin, there will be 11 people who will not get a heart disease or have a stroke because they have taken statin. There'll be 19 people who will get a heart disease or have a stroke even though they have taken statin. So, and then there's 70 people who will not have any stroke or any cardiovascular disease. So when you think about what's the benefit here, out of 100 people, 11 people will benefit by taking it. And there will be 19 people, even if they take it, they'll still not have any benefit from it. Then we need to think about what are the side effects of statin. So common side effect that a patient might be concerned about is muscle aches and pain. So if we think about how many people out of 100 who take statin will have it, then the statistic shows that it's 2 out of 100 people. So by having that discussion with your patient, the numbers, then the patient might be in a better position to make an informed decision. So this is where shared management comes in, where you discuss the pros and cons and help the patient to make a decision. Let's go over a second quiz now. So you've got a 75-year-old man who has chronic AF, is on anticoagulant therapy. Which one of the following is the highest risk factor of a major bleeding? Let me know that in the chat box. Okay, so we've got some people who think it's D, and then a few of you think it's B. Okay, the answer is hemoglobin under 13 grams per deciliter. So yes, Tahima is right. All of them are risk factors, but the highest risk factor here is associated with a low hemoglobin of 13 gram per deciliter. So some of you might be familiar with the orbit bleeding risk score for atrial fibrillation. You get 2 points if you're a male with a hemoglobin level under 130. If you're a female, then if your hemoglobin level is 120, under 120, then you score 2 points. And if you have a history of bleeding, for example, if you've had gastrointestinal bleeding or intracranial bleeding or hemorrhagic stroke, then you get 2 points as well. And then there is other risk factors where you can have 1 point for that. So for example, age over 74 years old, an estimated eGFR of less than 60, or treatment with antiplatelets. Is that making sense? Okay, great. So what we've covered so far is management of risk. So you see how you can identify the risk, assess the risk, and stratify the risk, whether it's a high risk or low risk. Next, we're going to look at how to identify uncertainty and how to think of uncertainty and handle uncertainty. So uncertainty is when you don't know something. So it's almost like somebody's blindfolded you and you can't see. So it's the absence of certainty. Compared to risk, uncertainty is where you don't know. There's an absence of data. You don't have a complete set of data to make a decision. Whereas risk is where you know what's the potential outcome and you can measure it. Whereas for uncertainty, it's just not well defined. So the potential outcome are not well defined. You don't really know what's going on. So it's a bit of uncertainty where you're not sure what's going on. And this is something that many GP trainees are not very confident at managing, and even some GPs struggle as well. So how do we manage uncertainty then? So let's go over case scenario 2. Mrs. William presents with tiredness for the last 2 months. So tiredness is one of those symptoms where it's very vague and it's something that's a bit uncertain as in what's going on. So to approach this case scenario, first thing we need to start by thinking about how to take a careful history. The history is really important to help us shed some light on the uncertainty. So make an assessment and develop a list of differential diagnoses. So when you have a list of differentials, that will help you to exclude anything that's serious and anything that's common as well, so that you can think systematically and logically how you're going to find out what's going on with this tiredness. And think about what's common and what's rare as well. So by taking a careful history, what you want to do is you take a history of the chronology of the problem from the beginning, what's happened, because that will give you more information to find out what's going on in the story. And then explore the presence of red flags, because these red flags will help you to manage this problem so that you can identify whether there's anything that you need to be concerned about. And also ask about other things that could be impacting the tiredness. For example, if somebody is not sleeping well, then they are not going to have a very good level of energy during the day because the sleep is not restorative. Another thing is mood. So if somebody's got depression and feeling low, then it's going to impact on their energy level. Other thing to consider is the appetite of that person, and also think about the psychosocial implication. So there's precipitating factors as well. So if a patient has been overworked or feeling stressed, then that patient could feel run down and tired. It's important that you sharpen the quality of your question and have a systematic approach, how you're taking the history and making an assessment. So what are the diagnoses that we need to consider then? This is not an exhaustive list. These are some of them, but there's a lot of conditions that can cause tiredness. So depression, acute post-viral fatigue, hypothyroidism, diabetes mellitus, sleep apnea, major organ failure. For example, somebody's got chronic kidney disease. If somebody's got malignancy, for example, cancer, they might feel tired as well. So think about your list of differentials when you're making your assessment. That will help you to find out more about what's going on in the case and help you with the uncertainty. So let's go for another quiz. How can you effectively manage diagnostic uncertainty? What do you think is a correct answer here? Everybody is saying C. Okay. Yes, that's effectively the correct answer. When you're managing diagnostic uncertainty, it's really important that we communicate openly with the patient about the uncertainty, involving them in the decision making. So there is a difference between doing it well and doing it in a way that will affect the patient's confidence about the treatment that we're providing them. So if you're doing it well, it's important that you show that you've excluded various things, and at this point you don't have any concern, and this is what you're going to do to find out what's going on. For example, it could be arranging investigations. Whereas if somebody is doing it in a way where they're just not sure what's going on and they also don't know how to manage that uncertainty, then the patient is going to lose trust. So it's important to be open. However, at the end of the day, you have the professional duty of making sure that you're providing safe care for the patient. So it's important that you take that responsibility and show to the patient what you're going to do to manage that uncertainty. So to be able to handle diagnostic uncertainty, then it's important that you consider what sort of investigation that might be useful, and make sure that you don't fall into the trap of over medicalizing a problem. So there are times when investigations might not be that helpful. For example, if patients already had extensive investigation and we still don't know what's the cause of this tiredness, then doing more investigation might not be that helpful, because could be the fact that the patient might have some other issues, for example, medically unexplained symptoms, and there might be other things that might be considered that would be more helpful. So also offer safety net advice, because with uncertainty, we're not 100%. There are times when things can develop later. So then if you have safety net at the patient, then the patient will know what are the signs to look out for, what are the red flags, and then they can represent so that they can have another assessment if things have changed. And then consider a follow-up appointment. So this is when you use time as a tool so that you find out what's going on. So for instance, if a patient presents with vague symptoms, then you don't know what's going on, you've done some tests, then it's helpful to follow this patient up, because if there's something that might occur, then it will take some time to evolve and you might find out later what's going on. And make sure that you involve the patient in the decision making so that the patient understand what's the plan. Because if a patient understands what you're doing for them, then they're more likely to adhere with the plan, and it's helpful for the patient to reassure them that things are being done. So far we've covered how to assess, identify, and manage risk. We've covered how to handle uncertainty. The next component is how to tackle ethical issues. The scenario is about a 15-year-old girl who is requesting to have contraceptive pill. She doesn't want her parents to know about it. So this is a bit tricky situation. Let's go another quiz. So you've got a 15-year-old minor who comes to your clinic seeking confidential advice about contraception. The minor demonstrates clear understanding of the different contraceptive options, their potential benefits and risk. However, the minor's parents are vehemently against the use of contraception and have explicitly stated they should be consulted before any decisions are made. How should you proceed? So we've got D's, a lot of D's. That's effectively the answer. Well done. So how do we think about this scenario? This is really important to be able to manage. And where ethical consideration comes to play, we need to understand what's the principles and how to make sure that we navigate these cases. And GMC Good Practice has got guidance on how to manage this. So we go through what are the ethical considerations in this case. You've got capacity, autonomy, confidentiality, parental consent. So these are some of the ethical considerations when deciding whether to prescribe or not. So when we look at capacity, there are four components that need to be fulfilled for a patient to be deemed to have capacity if we're doing an assessment. We assume that somebody has got capacity. Unless we suspect they don't have it, then we assess their mental capacity. So the first one is whether that individual understands the information relevant to a decision, whether they can retain that information long enough to make a decision, whether they can weigh up or use information, and lastly, whether they can communicate their decision. This could be by any means, and it's important that we have them to communicate. For example, if somebody is not able to communicate verbally, maybe they can do it by a written format. So when it comes to children, capacity in children, Gillick competence is useful. There is a confusion. Sometimes people use Gillick competence and Fraser's guidelines interchangeably, but these are very different frameworks that you can use. So we'll go through Gillick competence first. There's 6 different components in Gillick competence to see whether a child actually passes that test. The first one is to look at the maturity, consider the maturity of the child, the age, and mental capacity. If we're just considering the age, that's not good enough because we can't just discriminate on the age, because some children, they may be older, but they're not that mature. So think about these 3 components here. And then whether they can understand the issue, the pros and cons of the decision that they're going to make, and whether they can understand the risk, the implications, and the consequence of the decision that they are being asked to make, whether they can understand the advice or the information being given. So whether they have good understanding of the information that you're giving them, and also if there is an alternative option that's available, whether they understand that as well. And lastly, whether that individual can explain the rationale around the decision making. So it's more comprehensive than the last slide that we went through. So you can see the Gillick competency is a good framework to consider when you're thinking about whether a child has got mental capacity to make a decision or not. Now, you might have a child who's got capacity to decide what they're going to have for breakfast, but they might not have capacity to decide whether they'll go on contraception. So it's important to understand that capacity is dependent on what decision that the patient is going to make. The framework that we're going to talk about is Fraser's guidelines. So this is specifically used for deciding whether a child can consent to contraceptive or sexual health advice and treatment. I'm sure you've heard of it, and it's very important that you're able to apply it. So there are 5 components that we consider when we look at Fraser's guidelines. So whether the child cannot be persuaded to inform their parents or carers, whether the child understands the advice being given, they understand what it involves, whether the child's physical or mental health or both are likely to suffer unless advice or treatment is provided. That's a really important one. And then we look at the best interest of the young person, whether the advice needs to be given for the best interest, whether we need to treat them both without the parents being aware, without any carer's consent. And lastly, is it very likely that the young person is going to continue having sex with or without contraceptive treatment? If you find that these 5 components are satisfied, then you can follow the guidance and prescribe contraception, or you can provide the advice that's required to the child, especially when it comes to contraceptive advice or sexual health. It is also used for other things as well, for example, for STI tests and for termination of pregnancy as well. I'd like to share with you a story of a GP trainee who has actually failed her MRCGP exam because she had severe anxiety. She was dissatisfied with her preparation. And then some of you here understand that you're preparing for the SCA and you might be feeling a little bit nervous about how to approach these cases, ethical cases, and management risk. And it's really important that you prepare yourself. One of the things that Dr. Sanakan said is that the exam is a marathon, it's not a sprint. So if you're preparing to sit your exam, it's important that you're preparing early on and training as if you're training for a marathon. And if you're here today, then I can see that you're already doing the right thing and making sure that you're prioritizing your preparation. And one of the things that really affected Dr. Sanakan's preparation was that she had really bad anxiety to the extent that she had to see her own GP and go on medication. And it was really difficult for her to prepare. If you're feeling like you're struggling, and especially this new exam, you'll have to do it on one day. Stress and exam pressure can get the better of you. So it's important that you can manage that stress. And if you need to get the help, then make sure that you get the right support. And there's also professional support that's available. Because this exam can actually crush a lot of trainees. So make sure that you're getting the right support. So Dr. Sanakan sought advice and she got the right help. And one of the things that she found really useful was she joined the consultation blueprint program where we help her to manage her anxiety and get strategies to help her to pass her exam. And eventually she got through the MRCGP exam and she's currently working as a salary GP. She's now enjoying her life as a portfolio GP. She also does some shift in A&E. So it's really important that you have your goal and think about what you're going to do outside of training afterwards that will help you to keep going. Now, what I want to share with you is a little bit about what we do to help GP trainees like Sanakan. So sometimes you might find that you don't have time to prepare for your exam. You feel like you're not sure how to get along with this exam. And this is where it's very important to have a clear plan and a strategy so that when you're preparing for your exam, you know exactly what you need to do and how to get it done. Because if you've got a lot of uncertainty, you don't know, then it's very likely that your preparation is not going to be on point. So the three things like we focus on the program is mindset, strategy, and consultation skill. And you'll have a blueprint, as in how to build your foundation, how to consolidate, how to refine it. Especially if you're going to sit your exam, then you need to make sure that you keep refining and going through iterative feedback loop so that you refine your consultation. And the 12 blueprint cases are really important that you familiarize yourself with. Today, we're focusing mainly on the professional conversation and professional dilemma, but to make sure that you learn about each of these cases. And if you find that you have a weakness in any of these areas, then focus on practicing some cases and getting feedback on these cases. Because when the exams is going to actually occur, then if you haven't done the practice and refine, then you're not going to score very well. So it's helpful sometimes to have a look at how other GPs or more experienced doctors are consulting. And in the program, you'll be able to access that. I have got over 17 cases in the program where you can access how to actually score well for your exam. And also I'll give you a framework as in how to consult based on the 12 minutes consultation time frame that you've got. We've got over 50 testimonials, and here are some of the recent testimonials we've got. As you can see, the GP trainees who get on the program, they find it really useful, especially if they've struggled before. So if you're looking for dedicated guidance and support, I'd love to help you. And we're going to have another workshop on the 14th of October at 9 a.m. So if you want to actually go through live simulated role plays with actors and be able to get feedback, individual feedback to improve yourself, then I'd like to invite you to join, because this is where we have more time to dive deeper. So we'll have 4 hours, and you will get feedback, especially on cases such as professional dilemma and safeguarding. We have HIV as well. So it's really important if you find that your preparation is not on point to get the right support. So if you'd like to join, then you can scan the QR code, or you can go on bit.ly SCA program. In the program, you will get full support from me. You will get teaching, you will get the whole preparation blueprint so that you can organize your preparation. And you will also get invite to masterclass and workshop. So if you want to join a thriving community of GP trainees so that you can get support and guidance, so that you don't have to do it on your own, then feel free to join in. And the investment is £299. So that's a really good offer if you want to join today, because then any updates I'm going to have in the course, you get that for free. So there's also a personalized support one-to-one for those who want to have more attention. So there's a premium package, and there's also the VIP package. So if you're looking for one-to-one, I have got 2 spaces open, so you can join on that as well. So let's go back to confidentiality. So this is one of the things that some people might not be sure how to tackle. So if you've got a mom who's asking for information, and the child doesn't want the medical information to be shared, then it's important that you know when that you're able to share that information, and then also whether you're allowed to do so or not. So if you've got this minor's mom who is demanding to know whether her daughter is on contraceptive pill, what is the best course of action here? So respect the minor's confidentiality, provide information on the person's best interest of minor. Yeah, so well done. Right. So the answer here is A. There are some reasons where you can share the information. So we'll go over that now. So there are times when you might feel like you want to share the information, and ideally you want to get the patient's consent. So involve the patient in that decision. Explain why you need to share the information, and ask for the patient's consent. When do you think you might need to share the information? Then there are times when you might find that the patient they don't agree for the information to be shared, and this is when there are some grounds when you can disclose information where you can breach confidentiality. So the first one is if it's an overriding public interest that you need to disclose that information, then you can breach confidentiality on that ground. If it's the best interest of a child who doesn't have the maturity or understanding, then you can disclose information without consent. And if you're required by law, for example, you've got a court order, then you need to disclose that information. So there are things that you want to assess in the history to find out whether there's any risk of safeguarding issues. Ask about the nature of the relationship. How did the patient meet their sexual partner? Is a sexual partner in a position of trust? Is a young person too immature to understand or consent? And consider the age gap as well. So what's the difference in age between the sexual partners, and also the maturity or power between the partners? The bigger the difference in the age gap, then more likely that it could be a relationship that leads to abusive issues in the relationship. The other thing to consider here is signs of whether the young person is being forced or being coerced to do things that they don't want to, or they're being bribed or paid to engage in sexual activity, or if they're being forced to keep it as a secret. So if somebody is being forced to do something, or being doing something under duress, then it's not really consented. The next thing is to consider whether there's involvement of alcohol or drugs, because that's signs of possible abusive relationship. For example, if you've got somebody who is being given alcohol so that they can be influenced. So these are things that you want to consider in an ethical case for making a safe assessment and recognizing the safeguarding issues and concerns so that you can act on them. And if you need to share the information, then you can proceed by doing so. So ideally, you want to share the information with consent from the patient, but if the patient is not consenting and you have concern, then you can do so. So what we've covered today is how to identify, assess risk, and how to manage risk, how to handle uncertainty, and also how to tackle ethical issues that is related to contraception under 16. So if you've got any questions, please feel free to ask me any questions. I'll be here and answer your question. And if for those who have stayed until the end, I'm really grateful for you to spend your time with me today, and all the best in your preparation. And if you do need any help, please feel free to send me an email or feel free to ask me your question in the chat box, and I will be answering your question.
Hello, are you able to advise on time management during the simulation?
Time management is something that is really common issue that GP trainees struggle, and this is something where in simulation you will get personalized feedback, as in where you're spending too long and how you can change your style so that you can consult within 12 minutes.
Thank you.
I have a question too.
Yeah.
Yeah. So I'm just wondering, like there are 12 cases. So are you supposed to pass all 12 cases to pass the exam, or how does it go?
So the 12 cases, you don't have to pass all of them to actually pass the exam. It will depend on your overall score. What's your overall score? And if the overall score is meeting the threshold for passing or above that, then you will pass.
Mm-hmm. Okay, so is it the same, like, where you are judged against your peers, like, where your peer averages and then they set threshold? Is it like that again?
So you're judged on your performance, and then that score that you have is going to be used and calculated based on the cohort that you're sitting with. And that's when the score for the pass is going to be determined.
And is there like something like, are there any particular cases where, like, if you fail that particular case, it's a sure fail because you shouldn't be failing that? Is there something like that as well?
Not as far as I'm aware. So you don't have to pass a specific case to pass it. However, the more cases you pass and the higher the score in each of the case, the more likely that you're going to pass. But even if you fail a case that's very challenging, then you can still pass if you make up for that in the other cases.
Okay. Okay, that's helpful. Thank you.
Great.